How often have you heard this in conversation or seen it somewhere else on the internet, accompanied by photos of organized desks, shelves, and houses tagged with hashtag SoulOCD? Well, they are usually just talking about something trivial, like reorganizing the house to somehow resemble an IKEA showroom, or like color-coding their wardrobe, or even something like tidying up their messy desk. The term OCD stands for the acronym for Obsessive Compulsive Disorder, which will be used throughout this presentation later on, has become an adjective for being correctly organized and like things to look a certain way, usually so that the person saying it can self-define as someone with interesting habits. Most people don't give it a second thought, but they throw the term around casually. However, using the name of a serious mental health disorder as an adjective when describing typical habits or behaviors can somehow turn into a fun quirk, as anyone who loves the label may claim the diagnosis and thus trivializing and downplaying it. So before I continue my presentation, I'm going to greet Doctor a very good day and introduce myself as well as our team. I'm Shi Jin, and our group 14 will be presenting Obsessive Compulsive Disorder, OCD, as a psychological disorder. Zhen will be explaining the diagnosis, cause, and prevalence of OCD in more detail, and Ethel will be doing her interpretation of the signs and symptoms of OCD as well as the different perspectives viewing OCD. Jilin will be discussing the subtypes of OCD, and lastly, Lipo will be talking about treatment of OCD and to conclude our whole presentation. So let's get back to the topic. What's the big deal with the trivialization of OCD and what exactly is it? I'll first start with Googling what it's like to live with OCD from worst to hope. Picture standing in a room filled with flies and pouring a bottle of syrup on yourself. The flies constantly swarm about you, buzzing around your head and in your face. You swat and swat, but they keep coming. The flies are like obsessional thoughts. You can't stop them, you just have to fend them off. The swatting is like compulsions. You can't resist the urge to do it even though you know it will keep the flies at bay for more than a brief moment. So from this quote, we can briefly see that OCD consists of two components, obsessive thought and compulsive behavior. While I'll leave the details to Sam and Ethel, the obsessive part of OCD refers to intrusive, unwanted, irrational, and distressing thoughts that keep a person's mind occupied for a considerable amount of time. The compulsive part are repetitive behaviors a person performs in an attempt to counteract the distress or get rid of the obsessions, even though it doesn't actually help or as the person can control it. It can be time-consuming. This is very different from someone who likes to color-code their wardrobe because it's visually appealing to them, or someone who claims to be so OCD because they like their house to look a certain way. We can't judge that OCD isn't something that seems to be the reason why your desk is so neat, nor a personality quirk to describe someone with particular preference, or rather equating it to perfectionism, tidiness, and prudence. It is not something normal or enjoyable. It is in fact a distressing illness. It is a devil in disguise rather than a blessing or compliment. So that comes to the question, what makes OCD to be considered abnormal? When it comes to defining abnormality, the distinction between normal and abnormal behavior sometimes remain ambiguous even to trained professionals. Given the difficulties in precisely defining the construct, psychologists typically use a broad definition of abnormal behavior, which is that abnormal behavior is behavior that causes people to experience distress and prevents them from functioning in their daily lives. While there are also people that subscribe to humanistic perspective who offer a distinctive view of abnormal behavior that stresses the unique aspect of being human, such as embracing people with OCD as neurodivergent and seeing them as a part of normal human variation rather than assuming that it requires a fixing or a cure. But given its circumstances, if it starts to bother a person's day-to-day life to the point that it becomes distressing, they can see that OCD definitely falls into this category. Ethel will be explaining in more details later on based on the different perspective with OCD. Many people deem themselves perfectionists or detail-oriented, but we have to differentiate these habits from a real psychological disorder. Anyone can be obsessed or worry about something without it being considered a disorder. You can be obsessed with a new song, but you can still prepare your family for dinner, get ready for bed in a timely way, and get to work on time in the morning despite this obsession. Being anxious or nervous is a normal and inevitable reaction that everyone will experience from time to time. Making light of an illness like OCD can only increase the stigma that discourages people who are unwell from seeking help and suggests the idea that it's merely something trifling and common. Because most of the time, people who suffer from OCD are aware of and know just how irrational their behavior is, and they are already ashamed of their actions. Adding on the stigma by turning it into a threat and joking about it really doesn't help. It is also important to distinguish OCD from another disorder named Obsessive Compulsive Personality Disorder, OCPD, where the person exhibits an extreme type of perfectionism but is often unaware of it and somehow enjoys their rigid standards, and also wants others to do the same as them, but we won't go into much detail of it. In fact, according to a study by Powell and Myrie in 2016, it has been suggested that OCD is often misrepresented and trivialized for the public because it is much easier to understand the observable, compulsive behaviors than the intangible obsessive thoughts that characterize OCD. Let's take a closer look at the concept of disease trivialization as a three-part phenomenon which involves oversimplification, decreased severity, and mockery. First, oversimplification. While injury to the physical body can be easily observed and understood, many other conditions, such as OCD, are more complex and less observable given its various subtypes. Jillian will talk about that later on. When such diseases are oversimplified, this can promote misperceptions and toxic stereotypes and make it appear less complex. For example, in a fast-paced social media setting, the vast amount of information that quickly flows through a user's feed may prompt people with minimal exposure to OCD to rely on trivialized content and form their understandings of OCD and people with it from time to time. Second, skepticism about severity. As mentioned earlier, physical health concerns in general can take precedence and receive more attention than mental illness, and such willful indifference can trigger questions about severity of mental illnesses. Perceptions that the condition is not severe could undermine the efforts to describe the realities of OCD, such as leaving out the significance of obsessive thoughts but rather focusing on the compulsive behaviors, the need for additional research, as well as the emphasis on the importance of treatment, which will be discussed by Lipo in the very end. Third, mockery. The common representations and self-mockery of OCD, such as the example given at the very beginning of the presentation, like color coding of the wardrobe and associating it to OCD with a disease-related hashtag, can simultaneously tease those who have the actual disorder, hence belittling them and reducing the disease to non-detrimental behaviors. All in all, the trivialization of OCD can harm the public understanding of the disorder and shape people's impression of OCD and the individual's diagnosis of it. It makes the disease to be more approachable, but at the same time, distorts it to appear less severe, serious, and life-altering than it really is. Therefore, avoiding trivializing language is the first step of combating this stigma. Rather than uttering another "I'm also a little OCD," the least we can do is to offer some kindness, as we don't want to use words that can be hurtful to people living with OCD even if we didn't intend to. Knowing and understanding the role of language in OCD trivialization and also the diagnosis of OCD is necessary for societal and self-acceptance. And next up, I'll pass it on to Sam.
Hi, I am Samantha and I am the speaker for this part of the presentation, which is the introduction of OCD. Obsessions can be defined as the recurrent and persistent thoughts, urges, or impulses that are experienced at some time during the disturbance as intrusive and unwanted, and that it causes anxiety and distress for most individuals. Compulsions is defined as the repetitive behaviors, for example, hand washing and checking the stove multiple times, etc., or mental acts such as counting or repeating words. Or, in another definition, the behaviors or mental acts aimed at preventing or reducing anxiety or distress, or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to neutralize or prevent, or are clearly excessive. This relates to Jayan's points earlier. The obsessions or compulsions are time-consuming, for example, take more than 1 hour per day, or cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Obsessive-compulsive disorder sufferers frequently hold unhealthy beliefs. These beliefs may include an exaggerated feeling of duty and a propensity to overestimate threat, perfectionism, and an intolerance for ambiguity and overemphasis on ideas, for example, the need to regulate thoughts, and the idea that thinking a banned thought is just as terrible as acting on it. The level of understanding that OCD sufferers have regarding the truthfulness of the ideas that underpin their obsessive-compulsive symptoms varies. Many people have decent or average insight. For example, the individual believes that the house definitely will not, probably will not, or may not burn if the stove is not checked 30 times. A few, like 4% of viewers, have no insight or delusional ideas, while some have inadequate insight. For example, the person believes that the home would probably burn down if the stove is not checked 30 times. Or the individual is convinced that the house will burn down if the stove is not checked 30 times. Over the course of the illness, insight might change from person to person. Poor insight has been linked to worse long-term outcome. A lifelong tic condition affects up to 30% of people with OCD. When OCD first manifests in males as children, this is more prevalent. The themes of these people's OCD symptoms, comorbidity, cause, and pattern of family transmission tend to set them apart from those who don't have a tic disorders. When faced with circumstances that set off their obsessions and compulsions, people with OCD exhibit a variety of emotional reactions. For instance, a lot of people have noticeable anxiety. Others claim to have intense revulsion. Some people who engage in compulsions claim that until something happens, feels, or sounds exactly perfect, they feel distressingly incomplete or uneasy. People with the illness frequently avoid the people, places, and things that make their obsessions and compulsions worse. To decrease exposure to fear pollutants, those with contamination worries, for instance, could avoid public places, such as restaurants and public bathrooms, whereas people with intrusive thoughts about harming others might steer clear of social situations. Although there have been research and theories, scientists could not come up with the exact causes of the development of OCD. But there has been some more theories about the potential causes involving neurobiological, genetic, learned behaviors, pregnancy, environmental factors, or any specific life events that trigger the disorder in a specific individual at a particular point in time. These are the explanations for the potential factors. Biological factors. Some mental health professionals have urged us to consider studies on brain scans and related topics as evidence that OCD has a hereditary or biological basis. The findings of this research are frequently explained in the terms of chemical imbalances in the brain, flawed brain circuitry, or hereditary flaws. However, it is still not known how these differences relate to the precise mechanisms of OCD. There have been some brain imaging studies that show how different brain structures and abnormal functioning brain circuits of OCD individuals compared to the ones who don't have the disorder. This will be explained in detail by Ethel later. Psychological theories. Other research shows that there are other factors that play a part in the onset of OCD, which includes behavioral, cognitive, and environmental factors. For instance, the learning theory claims that OCD symptoms arise from a person learning negative ideas and behaviors toward circumstances that were previously neutral, which might happen as a result of life events. Numerous psychological elements that contribute to OCD have been extensively studied, and as a result, cognitive behavioral therapy, or CBT, has proven to be an effective psychological therapy, which will be explained by Lippo at the end of this presentation. Psychoanalytic theory. The psychoanalytic theory contends that OCD develops as a result of people's fixation arising from unconscious conflicts or discomfort they experienced during infancy or childhood, or the way a person interacted with his or her parents during childhood. But it is now less widely accepted than it once was, due to psychoanalytic therapy's failure to effectively treat OCD. The idea is currently mostly ignored. Ethel will explain more about this. Stress. Okay, so Environmental variables including stress and parenting methods have been linked to OCD. However, there is currently no proof of this. Although large pressures or traumatic life experiences might hasten the onset of OCD, stress does not really cause OCD. These, however, are believed to activate OCD in those who are already prone to the illness rather than cause it. OCD symptoms will worsen if ignored daily stress and worry in a person's life. The frequency and intensity of a person's OCD might be increased by issues at work or school and common problems that relationships can bring. Depression. Even though depression would, without a doubt, exacerbate OCD symptoms, the majority of specialists think that depression is frequently an effect of OCD rather than its primary cause. The prevalence of OCD. According to OCD UK, the 12-month prevalence of OCD in the United States is 1.2%, with a similar prevalence internationally, from 1.1% to 1.8%. Females are affected at a slightly higher rate than males in adulthood, although males are more commonly affected in childhood. And according to Din et al. 2019, OCD affects 1% to 2% of the population in Malaysia across all ethnic groups and affects both male and female. However, there is still limited published data in Malaysia with regards to the prevalence of OCD, though those which are available mostly cover comorbidity. Ethel will explain to you what the signs and symptoms of OCD and the different perspectives of viewing OCD.
Good day, my name is Ethel. Now I will share about sign and symptom of OCD and different perspective viewing OCD. The sign and symptoms of obsession-compulsive disorder often included both obsession and compulsions. However, there's a possibility of only experiencing obsession symptoms or only compulsion symptoms. Obsession are unwanted thoughts and feelings that keep recurring over and over again, while compulsion is the inability to resist or ignore the urge to repeat some action, even if it appears unreasonable and out of place to them. The example of obsessions included anxiety about being contaminated by objects touched by others. A student may be unable to stop thinking that she has neglected to put her name on a test and may think about it constantly 2 weeks until she gets her paper back. A man go on vacations and wonder the whole time whether he locked his house. The example of compulsions included hand washing until your skin becomes chapped, raw, or sometimes even bleeding. Checking doors repeatedly to make sure they are locked. Arranging the object's goods to face the same way. Until here, do you have some idea about the sign and symptom of OCD? Now, let us continue with different perspective viewing OCD. People have often attributed normal behavior to witchcraft and superstitions throughout human history. It was believed that abnormal behavior was caused by the devil or some sort of demonic god. As a result, authorities focus on driving out the source of abnormal behavior in an attempt to treat it. The remedy was often as painful as the illness itself. Nowadays, we take a more enlightened view of the world. We can understand OCD based on 6 perspectives. Firstly, we look at the biological perspective. According to a previous family and twin studies, OCD has a moderate genetic component. OCD is 5 times more common in first-degree relatives of people with OCD than in people without the disorder. The concordance rate of OCD among identical twins is around 57% and 22% for fraternal twins. The function of 3 neurotransmitters, serotonin, dopamine, and glutamate, is regulated by these genes, which have been implicated in the development of OCD. Moreover, research suggests that people with OCD may have different brain structure compared to those who do not. The orbitofrontal cortex is the part of the OCD circuit, which is made up of several interconnected brain regions that influence the emotion value of stimuli and the selections of behavior and cognitive response. The brain of people with OCDs appears to have abnormality in these areas when asked to look at the crookedly hung pictures or touch a dirty counters. So it is possible that abnormalities here are the root cause of OCD symptoms. According to psychodynamic theory, the id, superego, and ego are involved in determining a person's personalities and behavior. Our unconscious, primal drives or urge are represented by the id. The superego is what we learn as we grow up as known as societal rules, and what is and isn't acceptable as known as basically our moral compass. And when we don't live up with the superego standards, we may feel shame or guilty. The ego is the most rational aspect of our personalities, balancing the two by realistically satisfying the desire of the id. With this perspective, obsessions and compulsions are actually unconscious conflicts that you are trying to cope with it, and these conflicts come from a clash between id, usually a sexual or aggressive urge, and the superego, which is the desire to do the right things and follow socially acceptable behavior. To illustrate this, imagine in your mind's eyes the common image of devil and an angel on each eye's shoulder whispering in each ear. An individual with OCD are no longer being able to function normally on deciding between right and wrong. Whenever id and superego are in conflict, especially in extreme circumstances, a person is forced to manage them by repeatedly performing a task, including hand washing and frequent checking. Move on. In the behavioral approach, a neutral event is more likely to elicit fear or stress when associated with a stressful event. Someone with OCD only able to reduce the stress caused by the conditioned stimulus by performing compulsions. The conditioned stimulus could be a thought or something physical such as a doorknob or a bathroom. In reality, the ritual that people with OCD use to counteract the obsessions actually reinforced by the belief they need to do something to stop the obsessions, which result in being stuck in never-ending circles of obsessions and compulsions. The study of our thoughts and their relationship to our experience and actions is the focus of cognitive psychology. According to Paul Sokolsky's cognitive model of OCD, everyone has intrusive thoughts from time to time, but people with OCD mistakenly believe that thinking about an action is the same as doing it, failing to prevent harm is morally equivalent to causing harm, responsibility for harm is not diminished by extenuating circumstances, failing to ritualize in response to a thought of harm is the same as intending to harm, and one's thought should be controlled. Thought-action fusion is a concept of that thinking about an action is the same as doing it. For example, when someone with OCD has a sudden idea of robbing a bank, they might act as if they have already done it, making a thought just as bad as their action. Cognitive behavioral therapies aims to address and eliminate the thought pattern that link a thought to compulsions. Fifth perspective, the humanistic perspective, which emphasizes the potential for good and self-actualization in every individual, will lead to an existential crisis in those suffering from OCD. In these cases, the individual is trying to achieve self-actualizations but finds that they are stuck and unable to move forward. Those who suffer from OCD, which manifest as obsessions and compulsions, are trapped in never-ending circles as mentioned before. Obsessions and compulsions can be developed as a result of a basic need not being met in childhood or a sense of insecurity. Come to our last perspective viewing OCD. The social-cultural perspective considers a person's actions and symptoms in relation to their culture and background. Some cultures where religion and customs are held to the high standard may be linked to OCD. These factors are so ingrained and varied that they can affect the onset, outcome, and the response to OCD treatment. There is an emphasis on religion rituals that involve repeated phrases among Egyptians. For example, it appears that the prevalence of religions, obsessions, and compulsions make it difficult to distinguish between those OCD and those who are simply practicing their religion. Furthermore, obsessions were mostly associated with religion and cleanliness or purity among study participants in Egypt and Jerusalem, whereas themes among Indians and British participants were more about being ordinary and avoid aggressiveness. That's all for my part. Now, let me pass to Zelin.
Hi, I'm Zhen. As I mentioned before, I would like to discuss the subtype of OCD in our life. There are infinite types of OCD. It can impact any thought, subjects, persons, fear, and frequently fixates on what's important in a person's life. These are based on similarities in the content of obsessive thoughts and the actions a person takes to cope with them. Someone with OCD could potentially have any types of obsessive thoughts or any compulsive behavior, but these categories are seen most often. First one, organization, or also known as order and symmetry. This is possibly the most recognizable form of OCD. This time involves obsessions about things being implicitly the right place or symmetrical. People with this thought spend an inordinate amount of time arranging or ordering objects or visualizing symmetry. They may also have specific superstition about numbers, patterns, and symmetry. For example, someone may feel the need to have all hangings level, make all the labels on can in pantry face outwards, or keep everything on their desk completely neat. If the person does not perform the compulsory to make everything just right, they might experience distress or even those that the lack of organization will cause some unrelated harm to them or their loved ones. Next is checking, also called as doubt and incompleteness. Checking is an obsession in which a person is concerned about causing damage or harm by being careless. Their compulsions might include checking doors to make sure they are locked, stove to make sure the burners are off, and their wallet to make sure their credit cards, IDs, cash are all still there. They might have to check something multiple times or even stare at it for a long period before they can feel more at ease. The third type of OCD is self-control, a fear of losing control and doing something inappropriate, characterized many individuals experience with OCD. Some people may worry about shouting something in public, while others may be worried about harming someone, which ties into the aggressive or sexual type of obsessions. Any type of compulsive behavior may follow, but this kind of obsessions can also lead to isolation, as a person may avoid being around others. Other than self-control, sin, religion, and morality is also a type of OCD. Some people worry obsessively about being immoral or sinning. They may use prayer compulsively or ask for forgiveness over and over again. Next is ruminations. This time has similarities with intrusive thought-based OCD, but some key difference exists. The ideas that get stuck in the head of someone with rumination-based OCD are not repulsive and distressing. Instead, they might be philosophical, religious, or metaphysical conundrums, essentially questions that have no proven answers. People who experience ruminations will be stuck in this topic for a while and might ignore responsibility while they try to figure out an answers. Since these questions often have no definitive solutions, people might feel unsatisfied and empty after thinking about this topic for so long. In addition, harm to loved ones. For some people, the fear is not necessary that they will harm someone, but that some type of harm will come to their loved ones. For instance, some may obsess over the thought that their child will get hurt in a car accident. Compulsive behaviors could be anything, but are often used to prevent harm from occurring. Last but not least, contamination. Contamination OCD revolves around two general ideas. The first is the thought that people can spread non-viral illness through touch or proximity. The second is that everyday things, thoughts, and words can be contaminate a person, making them feel unclean. People with this type often feel the need to wash their hands repeatedly and clean items frequently to avoid spreading the perceived contamination. They may fear making themselves or someone else ill from being careless, or they might feel disgusted, uncomfortable around unclean items, which can lead to avoidance of certain objects, people, or places. These types of OCD are really just groupings of some of the most common symptoms. Someone with OCD may have any type of obsessive thought. Some other examples include fears about specific relationships, belief in magic and magical thinking, or obsessions about one's own body, such as breathing pattern or blinking. After understanding different types of OCD, let's think about how OCD affects life and relationships with people. Here is a case example to describe how OCD affects his life and relationship. Mark, who was interviewed by Queensland Health, is a father, husband, and public servant. Mark's OCD presents itself in different ways, and he can't always predict what will trigger his initial anxiety. For him, OCD presents first as an irrational thought that devolves into anxiety and action to relieve the anxiety. For example, one day he had the thought that the water which he was filling out his daughter's water bottle might be contaminated. He rationally knew it wasn't, but he had this worry, so he turned back to the sink, tipped it out, filled it again, and gave it to her. But then he worried again, so he did it 4 this time. Mark says he had to tell his colleagues at work about his condition to help them understand his behavior. The 3 things that are hardest for him are the guilty of having it, the shame of trying to hide it, and the humiliation when someone sees him. He had to pull all his workmates aside and apologize to them that they have to see his repeating things. Mark's OCD impacts his work life and his home life. By sharing this story, he hopes to dispel the idea that someone could control their OCD if they try harder, or that OCD is not a serious condition and it can be treated. Next, people will describe the treatment of OCD. Thank you.
Hi, my name is Hanglipo Angelina, anak perempuan Ayub. I'm a forensic science student currently in semester 2. Next, I'm going to present about the OCD treatment. First type of treatment is medication. OCD patients need to seek a professional treatment and healthcare from a psychiatrist, which first, patient will be introduced to a type of antidepressants, namely as selective serotonin reuptake inhibitors. These drugs help OCD patients by increasing the level of serotonin in their brain. The second treatment is relaxation technique. Relaxation technique is a type of treatment that helps OCD patients in their daily life. This technique can help by lowering the blood pressure, muscle tension, controlling pain, and also stress. For example, like meditation, muscle massage, and yoga. Meditation can help patients to focus on their thoughts, while muscle massage can help patients to relax their muscles. And finally, yoga can help the patient to build their strength, balance, and flexibility. The last therapy is known as cognitive behavioral therapy, and also known as CBT. It is a type of treatment that helps OCD patients with recognize their negative or unhelpful thoughts and also behavior patterns. Basically, there are 3 types of CBT, which is visual exposure, imaginal exposure, and ritual exposure. The first is visual exposure. Visual exposure is a type of method which the patient will be exposed into any situation or objects that can trigger their biggest fear or anxiety. This method is only to test for an actual contact with contaminants. For imaginal exposure is a type of method which the patient are ordered to do a visualization test, which is the situation that visualized must be a feared situation. For example, an individual driving on a road and then suddenly hitting a person. Lastly, the ritual exposure. It is referred to a patient which being refrained from a ritualistic behavior. For example, an individual leaving a kitchen without checking on a stove. Next, I'm going to do a review for overall parts in our topics. Diagnosing OCD is the presence of obsession, compulsions, or also both, which experienced by an individual. The symptom and signs of OCD consist of 2 types, which is obsession and compulsions. The definition of obsession is known as the recurrent and persistent thoughts, urges or impulses which experience at some time during disturbance as intrusive and unwanted that causes anxiety or distress. While compulsion is a repetitive behavior or mental that fuels by the individual to perform a response to an obsession. Basically, there are several factors that causes OCD, which include genetic or family history of OCD, other anxiety disorders, biological factors, psychological factors, life event, or environmental stressor. The danger of OCD trivialization, in which oversimplification, decrease in severity, and mockery will involve, as well as the stereotypes that people in general will associate with OCD. Next, the OCD symptom consists of 6 perspectives, which are biological, psychoanalytic, behavioral, cognitive, humanistic, and also social culture perspective. OCD presents itself in many cases. There are infinite types of OCD. For example, organization, doubt and incompleteness, self-control, sin, religion, and morality, rumination, harm to loved ones, and also contaminations. Finally, the last review is about the treatment of OCD. It includes 3 types, which is the intake of medication, relaxation technique, and also cognitive behavioral therapy. Cognitive behavioral therapy consists of 3 components, which is vivo, imaginal, and also ritual exposure. Finally, as a conclusion, we must understand OCD in a whole. This is in order to help and accept people who suffer from OCD. For example, this year in 2022, the International OCD Awareness Week, which will held on 9 to 15 of October. This event is set to advocate to raise awareness of OCD and related disorders. For example, type of event include OCD-inspired talk, art exhibition, and grassroots fundraisers by community groups, service organizations, and also clinics around the world. Finally, I want to conclude that sharing knowledge and reducing stigma means fewer people suffering in silence and acceptance by the person suffering and by society at large is the first step toward healing. Before I end our presentation, I want to inform Dr. Afizal that we already include all of our references for our presentations on the next slides. That's all from us. Thank you so much and have a nice day.